All right, welcome to Talking All Things Cardiopulm. I am your host, Dr. Rachel Barisi, and today we have a very special guest from halfway across the world, Dr. Aaron Thrush. Dr. Aaron Thrush, welcome and thank you for being on the podcast.
Thank you so much, Rachel. I'm happy to be here.
Awesome. I'm so excited to get to chat with you, get to learn about you even more, and have our audience learn about you. You are no stranger to the CVP world, but if you could just give a small introduction about you and your background, and then we'll really start to dive into things.
Sure. So I'm from Pennsylvania, and I graduated from physical therapy school in 2009. And I worked in the Philly area for about 7 years. And then I've moved over here to Abu Dhabi in 2016 with my family. In the US, I was beginning to be pretty active in cardiovascular pulmonary acute care ICU work, and then continued that once I got over here, primarily in our ICU settings in Abu Dhabi.
What made you go to, and we're going to go like way back, 2009 status. What led you to the acute care ICU route? Because that's not always the traditional route for PT.
Yeah. No, I didn't expect that when I was in school, when I graduated from school. It really wasn't on my radar at all. I graduated from school. I went to a kind of an acute rehab. Trying to remember even what the terminology is in the US. Patient rehab facility, right?
Okay, yeah.
Um, and I was really interested in neurologic as well as patients with amputations, and that's what I really tried to get off to the first few years, and I did, and I enjoyed it very much. I think I was asked to do a kind of a period of time in our long-term acute care hospital, which was attached to our rehab facility, and really just began to like that setting. It was a complex place. I was, revisiting a lot of things that I had learned about in school, but sort of, well, didn't learn, but temporarily learned exam
Yeah.
purpose, conveniently forgot. But and at that point, I remember thinking I did want to have a board specialization, and I was thinking neurologic specialization, and then I gradually started to shift towards cardiopulm, and I think I was attracted to it as well because it's a small group of people. It really felt special to me to have this niche that's kind of uncommon. And so from there, I started getting into more acute care and more ICUs, and I requested to do some rotations in our other hospitals within the same system, and that really like got me going in that direction.
Yeah, that sounds very familiar. I feel like the acute care setting sneaks up on people.
Mhm.
And when you're in it and you start to feel that vibe of complexity as well as the speed of service and the change in your day, there's something really enticing about it. I would agree. The physiology of it, the underlying complexity is always what drew me there. And then also the change that you see in those patients. But I think it's a good trade-off to the amputation neurologic patient population that you originally kind of fell in love with because there's so much entangled in the CVP aspect of that.
Yeah.
All right, so we're in the ICU, we're kind of getting our hands in things. I really wanted to talk about the international aspect of physical therapy because I think you have a very unique experience, and I'm actually just curious, like how did this even come about? How do you go from being an ICU therapist in Philly to Abu Dhabi? Like even help me to start to, cross that bridge.
Sure. Um, so I had some traveling opportunities before physical therapy school. I studied abroad when I was in college. When I was in physical therapy school, I had one of my clinical placements was actually in London. With one of my classmates, we went to London and had a rotation. So I'd kind of had that kind of exposure and loved seeing new places and learning new things about cultures. And I I I didn't really have a sense of how to bring that together with being a PT graduate and my first few years of school. I did kind of look for short-term things internationally, but I'm not sure how I kind of came across the opportunity here in Abu Dhabi. I think I was on the website for Cleveland Clinic in Ohio.
Yeah.
Um, just perusing job boards, just seeing what's out there in other major health systems in the US, and saw this hospital that had just opened, maybe a few months before I came across the job advertisement. So my wife and I had a few friends actually who were living here, and we reached out and learned about the place, and it looked like a great chance for me to get international exposure while also kind of being within the safety of like a hospital name that meant something. So
Right,
in case
familiar.
if I wanted to come back to the US or something, like this would be familiar and recognizable, and it wouldn't have been like a couple of years in another corner of the world that nobody could relate to. So I kind of felt good pursuing it for that reason.
I mean, that's amazing. How I'm going to ask a very naive question. How does the license aspect work? I know how it works in reverse, but moving to, say, a hospital that has the Cleveland Clinic name in a different country, are you licensed under the US PT license, or did you have to then go pursue?
Yeah, so I had everybody has to have a local license here that's issued by the Department of Health.
Okay,
Itself, the country is made up of 7 emirates, so they're kind of like 7 states, and they
okay,
operate a little differently in terms of their health systems and their licensing systems. But depending on the country you come from, for Americans and most people from Europe and Australia, your license will kind of automatically transfer into a local license. Of course, you
interesting.
submit in your license, and it has to go through a process of attestation and translation and all that. But it's just a process that takes some time, and usually your employer and your onboarding team actually takes care of that.
Okay,
For people coming from some other countries, there's an exam, a written exam, a practical exam. So it kind of depends where you're from, but it's very possible. It just takes a little bit of time.
absolutely. Okay, so let's talk about the language barrier. I feel like this would be such a different world to jump into, right?
Yeah, it is. Language, culture, beliefs about health and values, family, whatever. Like it's all intertwined, right? So our patients are a real mix when it comes to nationality and language. A, a majority perhaps are Arabic speaking, but we also have a lot of people from the Asian subcontinent,
Mm,
especially. So in Pakistan, Bangladesh, and everywhere else in the world. So we're very well staffed with medical interpreters for Arabic. We also have
okay.
interpreters for Hindi. We have interpreters for Urdu. We have a Russian interpreter that I found out about recently.
Oh,
Uh,
nice.
so we have those services, and then we when there's a language that's a little bit less common, we have our interpreter phones as hospitals do in the U.S. as well. But
Yeah.
we also have multinational staff that we can usually find somebody nearby who speaks a common language.
Okay.
So yeah,
So
but I
typically in-person interpreters throughout.
yeah, yeah, entirely in-person interpreters. I think. I mean, we do rely on family members maybe a little bit more than you would in the US.
Yeah.
That's not the preferred way, to really rely on family members, but that's often what we end up having to do here.
Yeah.
If it's not a service that we have in the hospital. As I said, we have the phones, but they're a bit tricky to use,
Yes.
especially, well, for a variety of reasons.
Yes.
So yeah, we kind of pull all these things together and do our best with it. But most people who have been here for a while have picked up a good amount of Arabic, especially as
Okay.
it relates to physical therapy, movement, exercise, body parts,
Yep.
symptoms,
Yep.
uh, and the same with Hindi.
Okay.
So that's the fun part as well. Of course, we don't rely on our skills because
Yeah.
they're not that robust,
They're
but
not necessarily up to par with the medical
they're
language.
yeah. But
That,
you get a sense for when you've established that relationship with a patient, their medical history. Now you're just doing some simpler things,
yeah,
and you can kind of get by in a safe way. But
absolutely.
that brings so much more learning to the clinical environment, right? It's not just learning medical things anymore. It's learning language and culture and how to interact with people of various backgrounds. So that's really, really fun.
Yeah, I would totally agree. I think I was having this conversation the other day that your bedside manner, your ability to connect with the human is sometimes even more important than the clinical skill. Do you feel like you lose some of that with the interpreter?
You do, and not only with the interpreter, but just because you are interacting with patients who come from very different walks of life, and of course, there's more that we have in common than we don't have in common. But at the same time, the way people have grown up and where they've grown up and how
Yep.
they do things sometimes very distanced from your own experience. So, um, the way you can build rapport sometimes quite easily in your home context because the language is so easy, the nuance of humor or
Yes.
relationship building, it comes naturally. But when you're in front of somebody who doesn't speak your language, they're 75 years old and the world they grew up in is very, very different from the world that you grew
Yes.
up. All these things, they do put a distance. So sometimes you feel like you're not connecting with people the same way. Um, but it's a trade-off, I think, in the end. Yeah.
I would agree. I mean, we also deal with, multinationalities and languages in the US as well, and we do rely on interpreter services. And we now use more of the virtual phone interpreter, and I find that much more difficult than an in-person
Mhm.
interpreter, especially for speed if something is going wrong. But
Mm.
you lose some of that humor, like the jokes don't go through if you're sort of connecting in that way.
Mm.
And then there's also a time aspect where you definitely require more time to have that translation back and forth. Do you find that that has been something that you've gotten used to?
Um, I guess we've gotten used to it, but it's still a challenge and we still sense it. And then you sense it even more in circumstances here where sometimes your message is actually going through more than one interpreter or person, right? You
Yes.
may have you may have a patient who's older and they speak a language that's actually very uncommon and their son or daughter speaks the
The
widely,
dialect.
and then that gets go
Yep.
to the interpreter and then it gets to me.
Yep.
So those scenarios you really feel how lengthy it is from a time perspective. um and I agree, like having the live interpreter with us is incredibly helpful. The other thing
Yeah.
I'll say about here is because we have those people so readily at our fingertips, we come to know them really, really well. So I feel like I work with interpreters as closely as I do with physical therapists and occupational therapists, and it's really
Interesting.
fun. They come to know so well what we're trying to do with the patients, and
Right.
they're also with those cultural religious things to help. Yeah, it's not like maybe in the US where your literal words go to the patient
Right.
and the interpreter is not meant to interpret, right? It's translation, I
Right.
suppose.
Yes.
Here the interpreters are very much contextualizing your message for your
Nice.
patient. It's a
I,
lot of fun.
that makes a
I like
big difference.
It makes a big difference. It makes a big difference. Yeah. So those are people that we work with so closely. I finished work today and I went and met one of the interpreters to go out for some Indian food before coming
Yeah.
here.
Nice.
Like
They're part of
closely,
your team.
yeah, they're part of our team. Absolutely.
So what about again, I'm going to ask a very naive question. What about PT to nurse, PT to physician within the context of the hospital? Are you using interpreters throughout, or is it mostly English speaking?
Entirely English. The
Interesting.
working the hospital is English. Any hospital actually that you would go to here, the professional language would be English. Of course, when you have people from the same country and they're informally communicating at work, they can use
Yeah.
their own language. But English is the
Primary.
of use. Yeah.
Interesting. Oh, I,
Yeah.
I would have assumed the opposite, which would make the transition as the English speaking PT much more difficult. So essentially, you're just dealing with the patients that have the language barrier versus the professional field.
Yeah. Yeah. For any job here, you need to be fluent in English. That's the working language. That's opposed to like our neighbors in Saudi Arabia, where Arabic is the language of the healthcare system. So oftentimes if I'm with a nurse, primarily a nurse, and I see that their Arabic is quite good, it's usually because they actually came to us from a hospital in
Okay.
Saudi. They really need to learn a lot of the
The
language.
medical aspect of it.
Yeah.
Yeah, which is different in general, right? I think sometimes we forget that medical interpreters have to speak the medical language or be able to interpret at a higher level versus just conversational. It's
Right.
just a very different context.
Yeah.
So let's talk more about you in the hospital setting. You have worn many hats.
Mm.
You are in clinic. I believe a congratulations is an order times two. Um, Maybe a promotion, got some research going on. Tell me about your day. Like, how are you involved in so many different things within the hospital?
Yeah, I mean, it's just I'm really grateful for a lot of opportunities and areas of growth since I've been here. It's been 9 years and was certainly primarily clinical for the first six, probably.
Okay.
I mean, even in those 6 years when I was fully clinical, there were a lot of opportunities. For example, I think everybody's familiar with Magnet, right?
Mhm.
Magnet is a oriented thing, but when
Yep.
we for Magnet, when we first opened, it was very multidisciplinary. We were writing the patient stories, we were leading the some of the unit-based councils. Um, so we had a lot of learning and teaching opportunities, even though, back then I was purely clinical. About 3 or 3.5 years ago, I was looking for opportunities to move into the research department.
Okay.
And leaders within these departments were really generous and came together and offered a solution that was better than I expected, where I would have a part-time allocation to the research department, um,
Nice.
working within the rehab department, but also kind of with a double allocation to research. So that the structure of that shifted over the years, but in essence, I still had some time, whether it was up to 2 days a week, down to 1 day a week. It kind of fluctuated, but I had dedicated time to research. So we could really put in place building registries, getting automatic data to use for things,
Yeah.
uh, doing a variety of research and kind of setting up the department for that. Again, that's shifted a bit over the years. Still do some of that. Um, and then, yeah, I came on as the education specialist about a year and a half ago. So that was overseeing all the professional development education, working with the local universities with their students and interns and graduate trainees, collaborating with universities and things like that. And then, yeah, in about July, I think I took over as the manager for the inpatient department. So that's been new for me, totally different. And that's seeing about 35 physical therapists and occupational therapists and a couple other support staff.
That's a big shift, right? I love the diversity in the day where you have a little bit of research, a little bit of clinical, a little bit of education. I think that's kind of like the perfect lineup where you kind of can dabble and use your skills in different ways. I do
Mhm.
feel the shift to management is sort of a different aspect of that.
Yeah.
How have you adjusted to that change?
Um,
Not to put you on the spot.
well, you know, I guess I'm well supported by the supervisors, the outpatient managers, the director of rehab. So I would start with, like, it's a great group of leadership to join.
Yeah.
There's a opportunity and potential in the department that I see. Um, so I suppose I'm trying to take my clinical expertise, say, and
Yeah.
translate that into leading a department, which they're very, very different things,
Yeah.
right? But bringing these different things together, I've been lucky enough to participate in a lot of leadership training here at CCAD as well. And now I'm really in a role where I need to put this into practice, right?
Yeah.
Motivating people, having high performers, low performers, communication,
Yeah.
strategies. And I'm just beginning. So I don't know what I can say about it, but I'm confident that, we're going to keep making progress,
Yeah.
and ultimately it's about the patients and the people on the team to make sure that we have the best systems in place. So that's what I'm trying.
I'm pretty sure everyone's confident, Aaron.
I hope so.
But but I do think that having the clinical expertise and having been in it
Mm,
typically makes you a better leader because you do understand the nuance. And I think when you do understand the nuance and you're not just kind of an outsider coming in leading a team, there is a different level of connection there and ability to make change as well as understand the clinician aspect. Are you still treating at all, or are you
yeah.
fully?
I am still. It fluctuates from day to day based on the need. We've been open for 10 and a half years, and we had our
Wow,
highest ever today. We had 200
cool.
on our physical therapy list. So I've been helping a little bit more this week.
Yeah.
Throughout the week, take 1 to 3 patients per day.
Nice.
Again, depending on what I have going on and what the team needs. So
Yeah.
yeah, but I end up helping anywhere. I mean, I try to help in the ICUs, but I end up going everywhere. Sometimes I beg. Sometimes I'm like, guys, please just give me a patient in the
Just give me
ICU.
one. Let me get
Yeah,
back in there. I
yeah.
was gonna ask, but you already answered the question. If you had to choose what area you are most passionate about, what you
Our car,
like,
yeah. Our,
cardiothoracic ICU?
yeah, I mean it's everything cardiac, as well as our heart and lung transplants,
Yeah.
all of our circulatory devices, everything cardiac, and that's what I love. Not just because of the patient population and the diagnoses, but the team is absolutely amazing, from the nurses to the doctors. Like everyone, you feel like you understand each other. You have a common goal. Um, People are so helpful. It's the best place.
I think being on a great team is very motivating and very contagious. I think there's nothing that you can take away from a team that you just like really want to be on. Tell me more about the ICU though, because I know you've had a lot of what's the word I want to say? A lot of input, a lot of practice. What about the ICU? What about the actual patient care that you enjoy?
Mm. Um, I mean, I'm drawn to cardiopulmonary, I think, because just the very basic principles of like volumes and pressures make sense to me, right?
Yep.
And you can understand it, neurophysical therapy is much less concrete and tangible to me.
Okay.
I like neuro a
Yeah.
lot, but I love just kind of the function of the heart and the lungs and the mechanics
Yeah.
of it all and
Yeah.
what we impact on as physical therapists. So, otherwise in the ICU, like I really love that it's very purely about the patient's needs for physical
Yeah.
therapy. I mean, I work on what we call the wards a lot as well, the normal floors. Um, and I feel like sometimes you get bogged down with difficult discharge things and
Hmm.
equipment and stuff, which is all really it's absolutely valuable. It's
Absolutely.
absolutely
Yeah.
the physical therapist brings so much value to that. But I kind of just love the purity of the ICU where you're doing what they need from your physiologic exercise activity perspective,
Yep.
and you're not so much influenced. You can really choose who you're seeing based on those needs,
Yeah.
not be unexpected discharges and stuff like
Right.
that.
The
So
the
I
immediate stat discharge sort of conversation, more
exactly,
the
yeah.
physiologic need to improve.
Yeah,
Yeah.
yeah. And just I think the complexity and the reliance, like you have to build successful relationships with so many people in order to function successfully
Yes.
yourself. You can't do it in a silo. You have to have people on board with you. So it's really all about building bridges, trust, give and take,
Yep.
understanding, like understanding your point, expressing your point of view, understanding
Hmm.
somebody else's point of view so that you can make the best decisions in these scenarios. So that's a challenge. And I really love that part
Yeah.
of it.
I agree. I tell all students that because I think it's a scary environment for a new therapist or a student therapist going into the ICU. There's kind of like this fear about it. But one of the things I always say is you're not alone. This is
Mhm.
a this is a team effort. You have to make those relationships to be a successful team member and to get the most out of your patient. But I almost feel like even though there's so much complexity in the ICU, especially with the patient population that you see, there is also so much safety because you have that
Mhm.
monitoring. You actually know the physiologic change that is occurring in real time. And I think when you're outside of that setting and you don't have that, immediate heart rate or um, art line that's coming up or the CVP pressure that's literally on the monitor as we're moving them, you have that safety net. You know what's happening. You can make good decisions based on what's happening in front of you.
Yeah. Yeah. Absolutely agree. Sometimes it's scary being out of the ICU.
I agree. You're like, I don't know what's going on here. All right, let's switch a little bit. You have made a huge impact in the CVP world in general, and you are very much a part of the CVP section here in the US. That is a huge feat. I mean, you are literally half a world apart. How have you become so um, established in the cardiopulm section and a part of that of the section itself?
Mm. Well, I guess I would start by saying there's never been a barrier on their side, which I really, really appreciate. Nobody has ever thought that I'm any less of a candidate because I'm not practicing in the US or
Yeah.
something. So that's been amazing. I think our academy is incredibly supportive. We're a small academy. Everyone kind of
Yes.
so it's a very close knit group, which I think does help. But it kind of started from 2016 when I sat for the board certification. I passed, and just a couple months after that, um, I applied for this job, or maybe I even applied before I sat for the exam. I can't remember, but I didn't have any firm plans of coming here until after I passed for board certification. And I remember when I got board certified, I immediately wanted to get involved in the academy. I had been involved professionally with the APTA in the what they used to call the health policy and administration section.
Okay.
I think it's the Leadership Academy now. So I was involved in things before, but it wasn't like the clinical aspects. So I think like a few days after I was board certified, I responded to an email about joining the specialty council
Okay.
for section, and I really didn't think they would pick me or they should pick me, but they did. I mean, I had just become board certified,
Yeah.
and it's a specialty council of 4 people, and it's a 4-year term. And I joined, I got accepted, and shortly after that, I said, actually, I'm moving to the Middle East. I hope that's not an issue, and it wasn't. So for those really the second, third, fourth year I was here, going to the U.S. for different meetings and things that the specialty council does. And that was my first kind of service in the academy. When I finished in 2020, I moved on to be a CCE, the clinical content expert.
Mm.
And I continue to do that till now. So people who are writing the exam items, I
Yep.
oversee and move them on so they potentially, in the future might be on the exam. Um, and I'm since last year, I've been the research and evidence-based chair for the academy. So, I mean, again, it's just such a wonderful group of people to be involved with,
Yeah.
and I think we may have discussed this briefly when we were together in person. Is it's also been a really valuable avenue for me to stay connected with this expertise that exists in this network in the U.S. Um, so that's just been really valuable to me. So I'm giving, but I'm also like receiving so much by being part of
Yeah.
that. I think is the case for everybody, right?
Absolutely. But what I did hear in all of that, besides the fact that you're very ambitious, is that you really seeked out a lot of these things in order to stay connected, right? You seeked out the opportunity in Abu Dhabi, you seeked out the opportunity in the CVP section. Um, I think that speaks volumes to you and also to kind of let the audience know that if you want something or you want to be involved in something, get after it, right? Like make that next step.
Yeah, for sure. There's so many volunteer opportunities, like small things that you can start with. And if you have that ambition and interest, it will grow. And, the people that you right now just listen to at conferences and read their stuff, you can work with them shoulder to shoulder. Like
Yeah.
it just takes some commitment and a few years of getting involved, and you don't have to be a genius or brilliant or anything. We just need people who do good work and
Yeah.
be part of some really, really good things. So definitely, you know whether you're just graduated or just newly a board certified PT, go for those opportunities because it's really, really valuable to you.
Absolutely. I also think there's something very special about being in the room. I was talking about this either in a newsletter or something, but even just connecting with you at the fall conference, like sort of increases that motivation to get going, or having those conversations with like-minded individuals, and maybe having that brave step to talk to the researcher who's like that name that's really exciting that you kind of feel is outside of the human realm, but we're all human and we all
Yeah,
have that ability to connect. And I think those in-person conferences kind of shine in those regards.
definitely. Yeah, it's that network thing, but it goes
Yeah.
beyond network as well.
Yeah,
Yeah.
absolutely. I think networking almost has like that scary word to it, or at least it always has been for me. But I do think there is something with that motivation piece of being in the room and hearing people talk about their research so passionately. And if something does excite you, that you can get involved. But I think
Yeah.
it's absolutely amazing, Aaron, that you are able to connect in two different worlds and make an impact in that kind of way. I think it really just kind of speaks to your character.
Thank you. Yeah. Yeah.
You're welcome. Tell me about
Mhm.
continuing education in international world. I could imagine you taking like courses literally like in Europe and the Middle East and kind of hopping around pretty easily. Am I incorrect in thinking this?
I mean, there's a lot of things happening over here. Yes. I think that sometimes the strength of continuing education in our specialty of critical care and critical care specifically, the strength is not there yet
Mhm.
locally as you may have in the US. What I've shifted to a bit in the last 5 to 10 years since being here is much more activity and participation in the medical conferences. Um, Everything here is a little bit smaller as well in terms
Okay.
of I mean, okay, the population, the health systems, the expertise of people doing whatever. So you here, I think you kind of have an opportunity to fit into these areas. So you can go to these medical conferences and kind of establish yourself as a local expert. Whereas in the US, you're one of many, you know?
Okay.
So I
Yeah.
enjoyed being part of and contributing to whether it's the ECMO and ELSO conferences, heart failure, whatever the case is.
Hmm.
A lot of opportunities for that. When it comes to my own kind of CME, we have MedBridge that I know a lot of people have in the US, so I benefit from that. I go to CSM every year. I'll do other online courses, but primarily online things is what I
Okay.
take it. I there there's definitely a growing interest, I think, in the GCC, the Gulf countries, in critical care rehab, and there's
Okay.
beginning more conferences, um, and I'm actually hoping to get a pretty good conference together next year, so people can
Oh,
keep that in mind and maybe travel over here to Abu Dhabi, because we really need it. We really need it.
that's that. First of all, wow, that's amazing. But I actually have the impression that almost there's like a head thinking sort of thing in where you are, where there's a lot of talk about ECMO and mobilization with our critical care patients. And even in the US, it's still not standard of care. So
Mm.
I was actually curious surprised to hear that it's still kind of growing.
It's growing. I suppose it's similar. I mean, I don't know how I can compare. Of course, there's some
Yeah.
centers that are doing really, really well. I mean, I have colleagues in Kuwait who are so involved in their ICUs with all of the mechanical circulatory devices and ECMO and doing amazing things. Saudi Arabia, they're doing it. In Qatar, they're doing it. Um, Again, it's I wouldn't say it's necessarily standard of care here. I don't think we're ahead of the US per se, but again, these countries are smaller, the populations are smaller. We
Yeah.
certainly have far fewer ECMO centers, so um, it might be a little more widespread. It's very hard for me to say,
Yeah.
but there's a lot of really good work happening here, and also the health systems are just have I mean, they're already modern, but they modernized so quickly, right, over the last 20, 30, 40 years.
Yeah.
And, the population is growing so fast. It's becoming a center for medical tourism. So we're attracting people from Asia, Africa, the Middle East, even Europe, even the US. One of our lung transplant patients 6 months ago came from Guatemala. like
Oh, wow.
because people are looking at the US, looking at Europe, looking at the UAE, and they're coming here.
Yeah.
So there's a lot of growth, and it's very exciting to be part of, actually.
That's amazing. I think the more we can just be involved in the growth as a profession
Mm.
worldwide is important. I guess my social media algorithm might be skewed towards the cardio pulm world, but I do see a lot of stuff coming out of the Middle East on ECMO. And I also know in like Europe, maybe the cardio pulm PT might have more say in certain things or be more standard in the care of, say, chest physical therapy or, those kinds of things where in the US, depending on where you are, you might have some, territory boundaries that you do have to kind of bridge, which is a different conversation.
Yeah. Yeah.
I think just making those connections, like you said earlier, is that fast track way of being able to get involved in different areas of that care.
Agree.
Uh, Anything else that I had on my list? We talked a lot about your eclectic career. If you had to choose between research, clinical, education, where do you think your heart lies the most?
I had to pick one.
Which hat are we putting on, Aaron?
Uh, Research.
Research.
I
Research is
think
the
so.
love. Well, that is a perfect segue. We are going to have Aaron back in the very near future because he has just, can we announce it officially? Officially have a new publication out specific to the framework of establishing mobility in ECMO. And so we're going to actually dive into that research the next time we chat with Aaron.
Yeah,
Do you
very
have
excited about
any lasting words for the cardiopulm community, Aaron, before we head out?
it. I can't think of anything,
That's
but
okay.
it's been enjoyable, and yeah, I think the takeaway is get involved, right?
Yeah, I agree. And I think we can definitely dig even further when we chat about foundations and framework of mobility in the ECMO setting. So you have time for our next talk to leave us with some, profound words for the community.
Thanks for the heads up.
You got it. Well, thank you so much, Aaron, for chatting with us and sharing your knowledge and letting us get to know you a little bit better. I hope everyone has a wonderful rest of your day and whatever you have to do, get after it.
Thanks, Rachel.
You're very welcome.